Hi, and welcome back to my YouTube channel. I am Dr. Ellie Kraft and also to the podcast. And today we are going to talk about the different types of breast surgery in a general sense. So, a little bit of breast cancer history. So, in the 1800s, late 1800s, a surgeon called William Halsted performed the first radical mastectomy in 1882. This is where basically the entire breast was removed, the entire pec muscle was removed, and all of the lymph nodes in the armpit were removed. Now, this is before any imaging. This is before, there's any kind of screening. So he was doing this after women basically appeared with lumps in their breast or very advanced disease. So that was thought to be the treatment, the best treatment for breast cancer at the time. And then as time went on, we discovered that surgery was incredibly morbid, which means so many side effects. The women were stuck with what's called lymphedema. That's where their arms are permanently swollen and they have to either wear a compression sleeve or lose use of that arm. It was very, very debilitating. And also they didn't have a breast or a pec muscle and just had like basically their ribs exposed on the left. So a very deforming surgery. And then as time went on, there was this shift towards doing less and less with the mastectomy. So leaving the pectoralis muscle, not having to take as many lymph nodes. That has happened over time. And I'm not necessarily going to get into too much of that right now, but I'm more going to focus on the surgical part. So the breast part of this. And basically what happened was studies started being done looking at what's called breast conservation, which is where we remove the breast tumor itself, leave the rest of the breast tissue, and follow it with radiation after. That's called breast conservation. They started comparing that with a mastectomy, which is where you remove the entire breast, but you leave a skin envelope in order to close the incision, essentially. And they did all these studies really in the 1970s, 1980s, and it showed that women had equivalent survival when they had a mastectomy versus when they had the lumpectomy with radiation. So that was really practice changing. And so women started going from having the mastectomy to having the lumpectomy when they could. And the original way that we were doing lumpectomies was just cutting right over the tumor, not putting any tissue back together. And then they would get radiation, and these lumpectomy specimens or the lumpectomy scars ended up looking kind of like a shark bite. People, if you think of like a mound of sand and someone comes in and takes a scoop out of that, that's what people would look like after this. And so in the 1980s, there was actually this big move towards what's called oncoplastic surgery. And that's where the plastic surgeons sat with the cancer surgeons and said, hey, your incisions, guys, look terrible. Maybe you could use some plastic surgery techniques to make this look a little better. And so it was then that the idea of oncoplastic surgery was born. And this actually was happening in Europe at the time. But my mentor, Dr. Melvin Silverstein, who started, the first breast center in the LA area called the Van Nuys Breast Center, he actually, studied with these surgeons in Europe and brought this to the US. And the idea that he came up with, or that he brought here, was essentially, bringing cancer surgery together with plastic surgery so that women could have their cancer operation and hide it and look very similar or as close to themselves as possible. And the other concept was if they had had children, if they had had some weight loss or weight gain, there's a good chance their breasts might have fallen at the time, or, gravity. They have essentially developed ptosis, or that's the medical word for like droopiness. And the plastic surgery technique of a reduction could be paired with a cancer surgery at that time to not only lift the breast, but remove the cancer. And when that was combined together, the cancer doctors were actually able to take out more tissue and have more sampling for the pathologist. And at the same time, also get a great cosmetic operation. The patients are so happy. And it was just kind of a beautiful marriage between these two specialties that had never worked together before. And so, long story short, Dr. Mel Silverstein basically brought this idea to America, and then he started training fellows in this. He first did this at the University of Southern California, and then he moved to Hoag Hospital in Newport Beach, where he continued to train fellows. And it has been the one program in the country that trains surgeons to do this oncoplastic surgery. And so he brought that here. I myself trained with him and completed his fellowship. And we have actually now created together, along with our other Hoag team, this standalone oncoplastic breast fellowship. Before we were part of USC, but that relationship has dissolved, and now it's a standalone fellowship at Hoag Hospital. But anyways, long story short, this is the introduction of oncoplastic surgery that happened. And so once this happened, we started studying it. We started saying, is this safe for patients? Is it not? And all of the studies showed, it really was. And patients were so happy, being able to look in the mirror and feel good about themselves, after the surgery versus before. There was a lot of psychological impact that happened when, someone looked very different than what they're used to looking at after the surgery. So that's a little bit of history about breast surgery. Now let's go through the various options of surgeries for different types of breast cancer. So the first option is for what's called a simple lumpectomy. This is where the cancer is removed from the breast and the rest of the breast tissue is left intact. This is followed by radiation, typically, not always. We are trying to de-escalate therapies that might not benefit patients, but those are case-by-case basis. And, I'm just trying to talk about kind of standard of care things. So the standard of care at this time for an invasive cancer, invasive ductal or invasive lobular, would be breast conservation. If that's available, that means that the tumor is small enough to resect it and still have tissue to put back together. Or the other option is for mastectomy. Now, mastectomy is where the entire breast tissue is removed and either the nipple or the skin is left intact. There's also something called a nipple-sparing mastectomy. Now, this is typically only possible when there's not a lot of drooping of the breast or ptosis, because moving the nipple itself after you've cleared out all the breast tissue is at a very high risk of what's called necrosis. So that means that the nipple would die. It's not impossible. It's just very risky in those patients to not only move the nipple, but to relocate it after the breast tissue and blood supply to the nipple has been removed. And it might be a case where a nipple graft, which is basically sticking the nipple on like a sticker, where that happens. And a lot of the time, the nipple can be very well tattooed or recreated in the office. So a nipple graft is not always the optimal option for patients. The nipple sparing mastectomy, like I said, is where the nipple is already in a good position where it hasn't drooped much and the breast is small enough that we can basically keep the nipple intact, shell out the breast behind it, and then you either replace the area behind that with an implant, or if you have a plastic reconstructive surgeon who's a micro-trained surgeon, they can also use sometimes your own tissue to fill in that gap. That where they bring tissue from your belly, but that's a very long operation. That's usually 8 to 12 hours. It involves an ICU stay typically after that. And so it's a big operation and something just to be aware of. Now, the most common operation that happens in breast cancer is the breast conservation. That's where, we remove the tumor, we keep the surrounding breast tissue. And the question is do you need the plastic surgeon there at the same time? Or is this some kind of simple lumpectomy where your breast surgeon feels comfortable doing it themselves? That's an individual question for each breast surgeon and their training. Some breast surgeons have a plastic surgeon in every one of their cases. Some other breast surgeons who have more plastic surgery training, they do a lot of this on their own. Also, there's a lot of breast surgeons that don't have access to plastic surgeons. So they are able, with the oncoplastic training, to do more and more for patients as far as the reconstruction goes. But typically, when a tumor is nice and small and you have enough breast tissue left, the breast surgeon can handle putting that back together. It's just when the area gets bigger, or like say more than 20% of the breast, classically, if you think of like a pizza, and imagine 20% of a slice being removed, that's typically where a breast surgeon can handle putting it back together. Versus when you get more of 20% of the breast volume, that's usually where you need to use some more special techniques to put everything back together so that the patient looks very similar to the way that they're used to looking after the surgery. So that's just a general overview of typically what's offered for different types of surgeries. So like I said, there's the lumpectomy. There's the lumpectomy with plastic surgeon involvement. So either a reduction, a lift, some kind of flap that's needed. That's the second option. And then the third option is, of course, for mastectomy. Now, as far as mastectomy goes, there is a survival benefit if you have a genetic mutation. So genetic testing is also super, super important in our breast cancer patients that are very young. So if they're less than 50, typically in my practice at least, I recommend that people get genetic testing in those scenarios to see if they have a gene that puts them at higher risk of cancer in the future. The other scenario are people that have a lot of family history. So their mom, their sister, their aunts, they all kind of had either ovarian cancer or breast cancer or melanoma or colon cancer or pancreatic cancer. Any of those cancers in general are, put off the kind of spidey senses in my head that we need to do genetic testing. And it's not that if you have a positive gene, you have to do mastectomies, but it's just, knowledge is power. And the more information you have, the more informed decisions you can make about your surgeries. So we're going to wrap it up again. Just in summary, there are 3 types of surgeries. So like I said, there's the simple lumpectomy, where you're not having a plastic surgeon involved and it's not requiring much reconstruction. Honestly, this is the most common scenario as breast cancer, especially if people are getting their mammograms yearly. We most of the time are able to pick it up at a point where we can just do a simple lumpectomy. If there's a bigger area that requires what's called oncoplastic intervention, that's where, we have to get a little bit fancier with what we're doing. We can involve a reduction at that time to kind of shift your own tissue into those empty spots. That's the second most common procedure. And then the third one is the mastectomy. Oh, and let's talk about the lymph node. So like I mentioned earlier, the lymph nodes need to be checked in the majority of situations where there's an invasive breast cancer. Now, if you're over 70 and you have a small tumor that has non-aggressive or recurrent features, that's typically a time where the lymph node can be omitted. There's also a new trial called the Ensema trial and the Sound trial that just came out looking at people of any age, but they have small, non-aggressive, slow-moving tumors, which actually showed there was no difference in patients who got lymph nodes versus not. That's also a consideration in some places, but it's something that, your individual surgeon needs to talk to you about if they're comfortable doing that or not. But, I'm going to assume the majority of patients are getting their lymph nodes checked. So what happens in that surgery is basically, depending on what your facility has available, likely your surgeon is going to use 1 or 2 modalities to basically map the nodes. And what they're doing when they map the nodes is they're giving an injection at the side of the breast and either around the nipple or around the tumor or really anywhere in the skin in the breast that then maps to the first draining lymph node. And the idea is that the node that is mapped at the time of injection is the same pathway that your cancer would travel. And at the time of the surgery, we use, like I said, one or two modalities to find that first draining node. And there could be, one or two or up to four realistically of those lymph nodes that drain the breast. And those are removed at the time of surgery and then sent to pathology to test them to see if they have cancer involvement. Now, that's usually done through the armpit. Sometimes it can be incorporated into the breast incision if it's close enough, but that's not the general rule. Most of the time, there's going to be a little incision in the armpit. Okay, so that is what I wanted to talk about today. Thank you so much for joining me again, and come back next time.